Appelbaum. I'm a computer engineering student in my junior year here at FSU Panama City. I'm founder of Pride Club, Gaming Club, and Planner Club here. I previously held the elections and programming committee chairs on Student Government Council. Currently, I work at Ascend, which is a grant-funded program to expand access to STEM and technical education in the 8 counties affected by the Deepwater Horizon oil spill. And with Ascend, my passion is educating people on esports. I also want to help them be involved and have fun while learning what STEM is and how it applies to their life, their hobbies, and their future. My brother, Wyatt Lewis, attended FSU Panama City before me and was heavily involved on campus. Dr. Clark?
Yes.
You know that.
Oh.
This started my university life with a lot of expectations that I would fill a similar role that my brother filled. People can look at me and say that I'm a southern, white, heterosexual man, and they'd be happy to talk to me about this, that, and anything else. What they don't know is that those assumptions are wrong. I use they, them pronouns, I am non-binary, and I am gay. And before I came on stage, I was wondering, should I say that I am gay? Am I okay to be out in the South? And I realized, well, here I am.
Yes, you are.
Thank you. So, I ask you to consider this instead. Don't make assumptions. You don't quite know who you're talking to and what their experiences may be. They could be like me, or they could be like my brother. We both look very similar, but we go through the world very differently. Take a second to ask yourself what assumptions you're making based on appearance. The assumptions made about me have caused me to live an almost dual life, one in which I meet the expectations set for me by my brother's legacy, and one where I'm authentically who I am. Being out about myself, or as I would put it, being authentic about who I am, is always a challenge around people I have in my daily life. These people may not see me as who I truly am. They may not see me as gay, asexual, and non-binary. They may treat me differently, isolate me, and question why I hid myself from them. But that's just what I did. I've had to limit who I allow into my life. I introduce myself with they, them pronouns to test the waters with new people. I'm mostly met with, okay, cool. But in the rare cases that someone is not accepting, I have to take measures to protect myself. I shouldn't have to be afraid of people not accepting my identity, nor should I have to limit interactions to stay safe, or hide myself to make others more comfortable. No one deserves harmful treatment because of who they are. Please be mindful of what you say and how you say it. This will build equity and diversity that our community desperately needs. In doing so, you are accommodating others by being supportive and inclusive. I want to introduce our next speaker, Dr. Jonathan Appelbaum. He's Laurie L. Dozier Jr., MD, Education Director and Professor of Internal Medicine. He is the chair of the Department of Clinical Sciences at Florida State University College of Medicine in Tallahassee. His specialty is internal medicine and geriatrics as well as HIV care. He provides primary care for the LGBTQ+ community in the Big Bend area, and we are reviewing some of the health issues and disparities within the LGBTQ+ community. Please welcome Dr. Jonathan Appelbaum.
Great, thanks Ethan for that introduction. I guess Father Ryan left the room, but that's a hard act to follow, and I really appreciate his perspective. I don't know about you, but I find it refreshing to hear his words from someone of the cloth. So anyway, we're going to change gears here, and before I start, I want to thank the organizers for asking me to come out here. Having been at the main campus, the big FSU, for 13 and a half years, this is the first time I've been out to this campus, and really impressed with, obviously, the beauty. Looking out there and you're right, we don't see that in Tallahassee. But also, what this campus has to offer, my impression of it as I've driven by on the bridge is a lot different than seeing it in person, so it's a great place. So this is what we're going to talk about, and there's a lot to cover in 30 minutes, so as I've told some of the people here, It's going to be more of a 10,000 foot level rather than, you know, a granular level, but hopefully you'll be able to follow me through this. These are my disclosures, and this is what we're going to talk about. So I approach talking to audiences, medical audiences, non-medical audiences, about medical care in the LGBTQ plus community. I think you first have to talk about the health disparities, and you have to understand the health disparities. So we're going to spend some time on that. And then I just picked a few topics that I really thought would be appropriate for this audience: sexually transmitted illnesses, HIV, transgender care. That is not all of health care for LGBTQ plus patients, but I really had to focus. And then I'm going to talk a little bit about some of the things I see as barriers to accessing care. So let's talk about who are we talking about? So some of this data is older. Unfortunately, we don't have a lot of newer data. But you know, who are LGBT or LGB? We'll forget about the T for now. I'll get to that in a minute. About 3.5% in various surveys say that they're LG or B. However, more of them will admit to same-sex content. So, so what this is telling me is it depends on how you ask the question, okay? So one of the things we teach our medical students, and I'm actively involved in teaching at the College of Medicine, is you ask a very open-ended question. What are the genders of your sexual partners, okay? That should open up the door. And then finally, there are a number of people who have same-sex attraction but never act upon it. So that's a larger number. When we talk about transgender demographics, the data is even more muddied. So we have some data going back now about 15 years. In Massachusetts, about 0.5% of the population. There was a large LGBT tobacco study in California in the 90s, about 0.1% of the population. The Williams Institute, which some of you may know, is a very large think tank in California that does a lot of research on LGBT issues, about 0.3% of adults. So that you think of the population, you're talking about 700,000 trans people in the United States. Petra Doan, some of you may know her. She just retired from FSU. In her specialty is urban planning. According to some of her data, it may be much higher than that, up to 9 million people in the United States. So, does anybody think that there's no healthcare disparities in the LGBT community? I probably wouldn't be here if that were the case. So unfortunately, yes, we have lots of data that would say that. A study of medical residents, these are doctors in training. They already have their MD, but they're getting their postgraduate training. Didn't ask sexually active adults about their sexual orientation. I'm hoping that since that data is now almost 20 years old, that things have changed. It's something that we insist that our medical students ask. And the reason that they were too uncomfortable to ask. They were uncomfortable to take a sexual history. 6% of physicians were uncomfortable treating gay or lesbian patients. In 2011, 24% of the responders to the transgender survey reported being denied equal treatment in a medical setting. And in a survey of medical students, again, this is older data, 15% reported seeing mistreatment of their fellow LGBT students, and 17% reported that they were in a hostile environment in their training. And then the data that many of you probably have heard, a study from California back in 2011 now, that medical students get an average of only 5 hours of teaching around care of LGBTQ patients throughout medical school. So I always like to do patient stories and how this is relevant to all of us. This is a 59-year-old woman who developed fever and chills after she'd had some head and neck surgery. The source of her infection was her prostate gland, but no one knew because no one asked whether or not she had a prostate gland. They made an assumption that she was a cis woman. Okay, this is Jake. Jake's a 45-year-old man who unfortunately came in with pain, and he had some x-rays that showed that he looked like he had cancer that had spread into his bone. And it turned out that he developed cancer because of residual breast tissue he'd had after he had a mastectomy, top surgery. Again, no one asked to find out whether or not Jake had any history that might be important here. All right. So when we talk about health equity, there are some policy, health political and law issues I think that are important when we talk about people in our community. Conversion therapy, okay? It's something that's been discredited by the American Psychological and Psychiatric Association and multiple other organizations, including the AMA, but it's still practiced. It's not banned in Florida, right? There are some jurisdictions, even in the state of Florida, that have banned this, but Florida is currently under a preliminary injunction that prevents the enforcement of the bans. And that's been pending in the 11th Circuit Court for, I think, quite a while now, and I'm not sure where it stands. Blood donation. So men who have sex with men can donate blood, but you have to say that you haven't had sex in 3 months. Is that fair? What about, no one asks the high-risk heterosexuals, to have a 3-month ban on donating blood. Transgender military service, thank goodness, the ban was overturned by the current administration. But if somehow the administration changes, who knows what's going to happen with that. But there is some good news, okay? So it's not all bad news. So physicians' attitudes have changed. A survey of San Diego physicians that was given in 1982 and repeated about 20 years ago, a little over 20 years ago. Would you admit a highly qualified homosexual, I'm sorry they use that term, applicant to medical school? In 1982, 30%, a third, wouldn't admit a gay person into medical school. And by 1999, that had decreased to 3%. 3% still a lot, but it's certainly better than 30%. Would you discontinue referrals if you knew that a pediatrician was gay? In 82, 46, almost half, wouldn't refer a family to a gay pediatrician. And in 1999, it was down to 9%. Again, I think that number is still way too high, but better. Important to, and something that I stress is that in order for us to feel comfortable going to a facility, we have to feel that they are accepting. So it's not just the physicians in an outpatient setting, it's the staff. And sometimes the staff in an office can either make or break the practice. So if your front desk staff isn't engaging and welcoming, then patients will not feel welcome there. And then the other thing that we encourage, and it's still not practiced, is the two-step process to collect gender information. So asking what was your gender assigned at birth and what's your current gender to be more inclusive. Okay, now I'm going to quickly go through some of the top health concerns by different populations. So in younger LGBT patients, some of the concerns that they will present with is concern about lack of family support, particularly if they've been kicked out because of the fact that they're gay or trans. If you look at lots of studies on homeless youth across the country, they are disproportionately LGBTQ+. The risk of bullying, sexual coercion, we've heard about that. Depression, suicide, obviously smoking, you're going to see in all of these categories, and substance abuse. In gay and bisexual men, concerns include, again, smoking, recreational drug use. The recreational drugs of choice change over time, so you have to kind of keep up on them. STIs, which we're going to spend some time talking about. Anal cancer. I wish I could say that there's been some consensus about screening for anal cancer, but it has not reached yet a consensus, and it doesn't appear in guidelines yet. and then personal safety and obviously mental health issues. In lesbian and bisexual women, again, smoking is a huge issue. Alcohol abuse, mental health, personal safety and violence, obesity, and because of that, and smoking, increased cardiovascular risk, probably less important, sexually transmitted diseases, and cancer. And the issue around cancer and women who have sex with women isn't so much that their risk is any higher, it's usually an issue of access to care and access to preventative screenings. And then transgender health concerns include, again, some of the things we talked about: smoking, alcohol, mental health issues, personal safety, access to gender-affirming hormone therapy, access to appropriate organ screening, and then gender-affirming surgery. We're going to spend some time on those. Okay, and then older, and I didn't put it in my bio, but my interest is in older persons because of my geriatrics background. I could spend an hour talking about aging and LGBT persons, but loneliness, so not having a family or even an extended family, support systems as aging occurs, and then the whole issue about if an older LGBT person has to go into a assisted living or long-term care, the fear of institutionalization and the real risk of having to kind of go back into the closet. So I'm going to kind of switch gears and now talk about some specific issues that I think are important for us. So sexually transmitted infection screening and management. As I mentioned, there's no consensus yet on anal pap smears, but it is recommended that that persons who are at risk do need to be screened for all of the sexually transmitted infections. And I'm talking about HIV and syphilis, as well as chlamydia and gonorrhea, and I'm going to show you some data in a minute on that. And important, and this gets back to getting correct information about your patient, is you need to find out sexual practices, because all of the organs that are involved need to be screened. So for men who have sex with men, inquiring what their sexual practices are, and you may have to screen the pharynx, the throat, the urethra, the penis, and the anal canal. Vaccinations are important, and particularly now that we have the HPV vaccine, which can prevent anal cancer and cervical cancer. That's really important. Testing for hepatitis C, and there has been in Florida, and some of you may have heard, a meningitis outbreak among men who have sex with men, and so making sure that the meningitis vaccine has been given out.
Forgive me, excuse me, I'm a transgender man, so we're all learning something new, but in regards to men having sex with men, that could be a little tricky, because we could be talking about assignment of birth, or we could also be talking about FTM.
Yeah, so basically so you're absolutely right. So it's really, it gets back to your sexual practices. So making sure that areas that are involved are screened.
Because it is stigmatizing, even if I were to go and donate blood.
Mm-hmm.
Yeah, because like I said, and also my medical record is updated. So even my birth certificate says no, but I still need to continue gynecological health.
Right, exactly.
And I have to answer that,
And I'm going to get to that in a little while, so hopefully I will answer that question.
okay.
So HIV prevention for folks in our community, it's important to understand what the guidelines are. The guidelines are that anyone between age 13 and 64 should be screened regardless of what their risk is, at least once in their lifetime. And then more often depending upon their risk. We have ways to prevent HIV transmission. The old behavioral methods, including condoms and safer sex, are still valuable. But we now have biomedical ways of preventing HIV. We have PrEP, and if you are in a relationship with someone who's living with HIV, as long as that person has an undetectable viral load, they cannot pass HIV onto a sexual partner. We call that treatment as prevention. So you may have heard the term U equals U, and that means undetectable equals untransmissible, okay? One of my dear friends who is living with HIV and unfortunately does not have an undetectable viral load always asks me to put down that virus does not equal value, so it means that if you cannot get an undetectable viral load, it doesn't mean you have any less value. So that's an important thing to understand. All right, so I'm going to give you some data, just important to know what we're talking about. I'm not going to use the pointer. So last year there were about 36,000, a little under 37,000 new HIV diagnoses in the United States. You may have heard that there's a plan to end the epidemic by the end of the decade. So the plan is to have no more than 3,000 new infections by 2030. What this slide shows is the health disparities we have among HIV. So while the black population in the United States represents about 13% of the population, they represent a huge number of that 38,000 new infections. So the black and Hispanic contribution to that number of 37,000 is huge compared to their population in the country. So I mentioned about PrEP. Just for your information, we have 3 approved regimens. 2 of them are oral, and this is considered to be a grade A recommendation by the United States Preventative Services Task Force, which means it's should be covered by insurance under the Affordable Care Act. There's also a new injectable, an injection that's given basically every 2 months. You don't have to take a pill every day. There are some non-approved regimens that have been studied in other countries, something called PrEP on demand, but it's not, I spelled it wrong. But anyway, should be, it's not yet approved in the United States. It's being studied and seems to have very good efficacy. And then there's some investigational things, including long-acting implants, something almost like what we use for birth control, where something is implanted under the skin and may last for 6 or 12 months. Unfortunately, we see disparities in access to PrEP. So only 11% of sexually active young people between 16 and 24 who are eligible for PrEP were prescribed it in 2018. So we have an age disparity, and we also have a gender disparity. Women are much less likely to get PrEP prescribed than men. And then again, health disparities, we also see ethnic and racial disparities. If you're white, you're more likely to get PrEP prescribed, and you're less likely if you're black or Hispanic. Okay, now talking about what's going on in Florida, you can see that this is the number of HIV diagnoses in Florida. There was a huge drop between 2019 and 2020, 1,000 fewer HIV diagnoses. Anybody, did we do a better job? Was it our Department of Health that was really doing a bang-up job?
No.
Basics. I do prevention.
So what caused the drop there?
Testing?
COVID.
Testing, yeah.
So the huge drop, not only in Florida, but across the country, was because fewer people were coming in to get tested because of COVID. Everybody, and the CDC data is always, and the Department of Health data is usually about 18 months behind. We fully expect when the 2021 data comes back, it'll probably be back up again. And I just want to point out where we are in Bay County, we're not immune to HIV. We're certainly not the epicenters in Florida. We're not Miami-Dade, Broward, Orlando, Jacksonville, and Tampa, St. Pete, but we have quite a lot. Actually, a little further to our east, Gaston County is kind of dark there too. They've always had a very high percent of new HIV diagnoses. And again, I want to point out again health disparities that we're seeing here. You can see in the yellow bars is the percent total population in Florida by whether they're white, black, or Hispanic. And then you can see in the orange bars, the percent who were diagnosed with HIV. And you can see, for instance, the black population is 15% in Florida, yet make up 40% of the new HIV diagnoses. So again, huge disparities here. I would be remiss if I didn't talk about the contribution also of other sexually transmitted infections. And Florida has been in a epidemic of syphilis in particular. You can see the diagnoses of syphilis has gone up and continues to go up. And just to show you a little bit of different chlamydia, but the trajectory prior to 2020 was up, as is gonorrhea. So we always tell our students is that if you have one sexually transmitted infection, you are likely to have more than one. The good news here is what we're looking for is the final bar, which is folks who are living with HIV who have a suppressed viral load. It means they're taking their antiretroviral medication and can't transmit HIV. And you can see if you look at the percent of people who have HIV, almost 70% are virologically suppressed. That's actually as good or better than what's going on in the rest of the country. Okay, I want to switch gears, talk about transgender care. Hopefully I'm doing okay on time. Really important to find competent providers, and you can find providers, but they may or may not be competent in caring for the transgender population. We use what's called an informed consent model, which is really the current way to provide care to trans persons. Not the old-fashioned gatekeeper where the medical provider did everything they could to prevent that trans person from accessing either gender-affirming hormones and or gender-affirming care. So it's really important for the provider to provide access to the gender-affirming hormones and to obviously monitor them. It's not that you write a prescription and say goodbye. You need to follow up. And you need to provide access to gender-affirming surgery. The limiting factor is primarily insurance coverage for this. Interesting, the Florida State insurance coverage for students will cover transgender surgery, but the insurance coverage for the faculty won't.
Wow.
It's very interesting. It used to be you couldn't find a surgeon who was competent in trans surgery. It's actually becoming quite a niche specialty or subspecialty of general surgery, and many centers now are investing in basically comprehensive transgender surgery programs, including University of Florida and Miami. As someone who I'm a primary care doctor, as someone who provides care to trans patients, you don't have to go to an endocrinologist. In fact, if you want an appointment with an endocrinologist, you probably have to wait years, at least where I practice. And it's really, the goal is to facilitate affirmation and to relieve the symptoms of gender dysphoria. And I look at it as providing two categories of care: general primary care, okay, as well as specific care for trans. Just so you know, there's lots of guidelines out there. The World Professional Association of Transgender Health, or WPATH, actually this month just released their updated version. Something we've been waiting for because the previous version was about 10 years old. But even the Endocrine Society, these group of academic endocrinologists, have their own guidelines for trans care. University of California, San Francisco has a wonderful resource, and many LGBTQ health centers across the country provide their own standards of care. It's always hard for folks to find competent providers. There's a couple of resources. The GLMA used to be the Gay and Lesbian Medical Association, now it's called GLAMA, has a provider resource. getting back to what I heard before, it's important that you know what anatomy your patient has, okay? We call taking an organ inventory, asking what organs are still there, what organs were they born with, what organs are gone, because you need to screen for various illnesses, including cancer, in the organs that remain. It's also important. And I'm talking from my experience. I'm obviously not someone in that community, but I have witnessed increase in mortality compared to the general population, and there are lots of data that says there's an increased risk of HIV, suicide, and drug-related deaths. And depending upon the subpopulation, there's a much higher risk of HIV in the Black trans women population compared to the general population. Depression. This is the 2015 U.S. Transgender Survey. There's actually a more recent one, but almost half trans people who answered the survey had considered suicide, and a quarter of them had actually planned a suicide. And 40% had actually attempted at one point. So those are astounding data.
Excuse me.
Yes.
I looked at the US statistic, do you also have something for Bay County statistics?
I don't.
Well, please, hold, because you're at the CPC. I love you.
What was that?
Please try to find some FSUPC, Bay County statistics.
Yeah, that would be really hard to find because I'm not sure everybody's collecting the data.
We're committed to, LGBT transgender healthcare.
Sure.
Yep.
We're out in the south, so this is Bay County.
Yeah, I understand. But if the data's not there, I can't make it up.
Well, we're right here.
Okay.
I don't have the data.
And then I just want to let you know what are some of the gender-affirming surgical options, including fillers, facial feminization, chest surgery, voice surgery, laser or electrolysis for hair removal, and then there's obviously genital confirmation surgery. And what I tell my patients, to find a competent surgeon. I'm always looking for competent surgeons. Many of my patients actually come back and tell me, who they've had surgery with, and so I kind of keep a referral list. And so, just sort of in summary, and I'm sure there'll be questions later. Hopefully, you understand that there are significant health disparities. The good news, I think, that we're training more competent, health professionals, and not just in medical school, but in nursing, PA, and other specialties. But there's still issues on access to competent primary care. Important issues that we talked about, STIs and HIV. I didn't really even get into mental health and substance abuse, but that's a whole nother issue. And then I think that competent trans care is improving, but still it remains hard to find. So, questions now, or should we wait till later?
Wait till later. Yep.
At the end, okay. Thank you.
Awesome. Thank you.